presentar a nuestro ponente con el tema Interpretación y resultados de la oscilometría de impulso en México. Es el doctor Lennart Landablad. Él es profesor asociado de medicina, originario de Suecia. También tiene una nacionalidad americana y está trabajando en Quebec, Canadá. Él tiene sus estudios de la Universidad de Lund University en Suecia. Tiene PhD en fisiología clínica experimental. Es profesor asociado adjunto colaborativo en estudios múltiples de fisiología pulmonar. Es un experto en fisiología pulmonar. Tiene diferentes actividades, tanto en empresas o laboratorios, así como en Thoracis Medical System, más de 60 publicaciones en extenso y también más de 60 publicaciones en abstract y diferentes cartas al editor. Le damos la bienvenida al doctor Lennart Landablad, que pues su currículum es bastante extenso, la verdad. Nos mandaron 30 páginas, pero estamos sintetizando lo más posible y estamos seguros que vamos a disfrutar muchísimo la experiencia que tiene el doctor y gracias por compartirla con nosotros. Les recordamos que al final de la sesión, en lo que es el chat, pueden ir haciendo sus preguntas. Vamos a tener un traductor para hacer las preguntas y también al final de esta sesión les recuerdo que tienen que contestar un breve cuestionario para obtener los puntos de certificación de Cónica. Bienvenido, doctor, y cedemos el micrófono al doctor Lennart.
Thank you very much for that very nice introduction. I'm really pleased to be here with you, and I'd like to introduce my colleague here, Natalia Restrepo.
Hola, buenas tardes, buenas noches a todos. Yo hago parte del equipo de diseño y desarrollo de Thoracis y estoy aquí para cualquier pregunta o inquietud que tengan en español, si se sientan un poco incómodos o preguntando en inglés. También hago parte del equipo, entonces cualquier inquietud a sus órdenes.
Yeah, so without further ado, I will just start sharing my screen here with my presentation here with you. We are going to talk about oscillometry, of course, and how we can use that to our advantage in terms of diagnosing patients with lung disease, excluding those who don't have any disease actually, and of course how we can use this technique to monitor patients and make sure that they have adequate treatment. So this is sort of the overview of what we're going to do tonight. I hope to be able to share with you just very introductory, very briefly, the operating principles. That's not really the goal to go into depth at this talk about that. I'm happy to do that at some other point in time. But we're going to talk a bit about how to use the tremor flow. We're going to talk about the outcomes that it reports. And I have a bunch of clinical examples here that we can look at together, and I'd be happy to entertain any questions you have. So don't be shy to ask questions. And as Natalia said here, I'd be happy to use her as an interpreter, or if you go via an interpreter at your place, if you feel that English is an obstacle to you. All right, let's move. So lung mechanics, what is that? Well, we humans, we try to understand the world in terms of math. That's just the way it is. We count everything. We measure distances. We check speeds and whatnot. And when it comes to lung mechanics, we're not any different. We just look at what the physical properties of the lung is. And in doing so, we need to measure. What do we measure? Well, because this is about moving air in and out of this organ, lung mechanics really is the relationship between pressure, flow, and volumes in the lung. And if you haven't measured these three, you haven't done a complete assessment of the physical and physiological properties of the lung. That's important to understand. And it's also important to sort of realize that in order for this to be meaningful to do lung mechanics, it needs to be sensitive and specific enough so it can actually detect the changes that are related to pathology of this very important organ in our body. You have to remember, most people die because the lungs give up, so they're kind of important. So history of oscillometry, well, so this goes back to 1956, and this is one of the very earliest setups. So when you see a tremor flow, be aware, it could be a lot worse. This is just one of the setups they had. They had a polygraph here, they had a loudspeaker, they had some sort of gadget here to measure lung volumes, and but some things you can actually realize. They had the mouthpiece, they oscillated with some sort of pump, they had the transducers. All of that has just been miniaturized, and this big hunking thing here has now been reduced to a little computer, a laptop. So I think an important thing that was realized already back in 1956 is that lung mechanics is not the same every time you measure it. It is actually depending on a number of things. And one of the more important things is actually the frequency. So they realized that there is a frequency dependence in, and they are looking at compliance here, in asthmatics. And here we're looking at people with emphysema, essentially chronic obstructive pulmonary disease, COPD. So we can see, depending on at what frequency the patient is breathing or this device is oscillating, you will get different results. That's highly annoying if you're not aware of it. If you're aware of it, you can use it to your advantage and actually learn something about the lungs by oscillating at different frequencies. And that's really the core of oscillation mechanics. By using different frequencies, we can learn different things about the lung that we otherwise wouldn't know. So you already figured out that you need some sort of investigative paradigm here. I mean, one thing to measure something, but if you don't know what this measurement is relating to, it's really worth nothing. So this needs to be related somehow to the anatomy or the pathology or a structure in the lung. And we do that by linking them via some sort of model, a mathematical computational model that links the structure to the function. So this goes back and forth. We know something about the lung, we measure it, and we see a change. We correlate that with the changes in the lung. So this can be done in a number of different ways, which we're not going to go into here, but suffice to say, imaging is one important aspect. I'm going to show in a little slide later on today relating to that. The basics of doing lung mechanics are actually relatively simple, at least at the face of it. The model we are using is really a pipe and some sort of expandable or elastic compartment here, a balloon if you so like. And we are looking at the resistance, we're looking at what's called reactance and inertance. Reactance actually includes both compliance and inertance. So it's sort of a complex concept, and we're going to try to sort this out today. And this is going to lead into how you can interpret and understand the lung mechanics that you're doing with your patients. But the important thing is that if something happens in the airway compartment of this model we have here, that's going to lead to an increase in resistance. And that's kind of intuitive. The tube is narrowing, resistance goes up because the flow will be impeded or by this restriction here. And similarly, if something happens to the tissue in this elastic balloon here, making it stiffer or more loose, either way, that's going to affect the reactance part. So we're dealing with resistance, reactance. Reactance is made up of compliance and inertance. So some things here too for the quiz. No, we're not going to have a quiz, but if we had a quiz. So all this can be calculated by just measuring these three things. And that's exactly what we're doing with the devices out there. And this is the equation, a simple equation that might help you understand how these things are linked together. This is not necessarily the way we use it daily, but it helps understanding how the science is behind this whole idea. And as I said up here in my headline here, this applies to mice, it applies to men, it probably applies to crocodiles and whatnot, but any lung that looks like a mammal lung will actually follow this simple linear equation. with flow relating to resistance, volume related to compliance of lung, and we have acceleration, which is related to the inertance of the gas. So this makes up what we call resistance reactance. So now that you've seen this slide, remember you've seen it. You don't need to remember anything about it, but you have seen it and you know that this is based on physics, first principle physics. How can we acquire lung mechanics data? Well, we can do it the old-fashioned way, if I might be a bit facetious here. You can have the patient perform a maneuver, which is essentially spirometry. And I'm assuming that everybody in the room knows roughly how to make spirometry. I'm going to show some examples later on that not everybody knows how to do spirometry, but that's a different thing. Resistance and compliance is not anything that is necessarily done with oscilometry alone. This is something that you can do without that. You just need a few transducers, and it's good to have a body box, a plethysmograph, where you can put the subject inside and do some maneuvers, and you will calculate resistance and compliance of the lung. And you will get a really good measurement of lung volume. I think that's actually the best use of a plethysmograph, looking at lung volumes. Sorry if there are any pediatricians in the public, but most of the time pediatricians just make educated guesses. I'm not really trying to be fun here because this is a serious thing. The problem with young kids is that they cannot perform spirometry. They probably freak out if they put in a plethysmograph locked up there for a few minutes. So we're sort of limited what we can do in kids. We can do imaging. Imaging is actually not bad. It's very good. You can resolve a lot of structural things there, and you can see a lot of pathology there, assuming it's visible on CT or MRI. Of course, lots of limitations here. Big devices, expensive to run. You expose the patients to radiation with CT. So it's not very feasible to do on a regular basis. We can apply a known perturbation, a known sort of disturbing signal to the lung. And this is exactly what we're doing in oscillometry. We just don't care about the patient performing a maneuver. We just want the patient to be sitting there breathing gently, and then we apply the test signal. So, and this is a question I get quite often, so I actually edited this slide a little while ago, thinking about it, to sort of try to help understanding how spirometry and oscillometry are different and how they actually are more additive to one another, and that you can actually learn more from doing both than only doing one. They both have their place in diagnosis and therapy. So spirometry essentially is a question of that the patient applies the test signal. Oscillometry, the device applies the test signal. The difference is also in what we get out of it. Spirometry at the core of it is really how quickly, how readily can you empty your lungs from a total lung capacity, from that full breath. And from this, it's also easy to understand if that full breath is not full enough, well, then you can't really rely on the test. If the emptying of the lung is not complete, well, then you cannot rely on the test for that reason either. And if the force out is not a maximum force, well, then you can't rely on it either. But all of that can be taken care of with good coaching, good trained personnel, and a patient that really engages in this testing. Oscillometry is done right around the functional residual capacity. So we're not interested in the patient doing any deep breaths or exhalations or anything. They should just do tidal breathing. But this also sort of illustrates the difference between the techniques, not only how the test signal is done, but also where and how it measures. So when you force air out of a lung, the lung might, reach a stage when it can't increase the flow anymore. So you reach flow limitation. With oscillometry, you can actually see signs of airway closure here too, which I was going to talk about, but that's going to be right around FRC. And the resistance and compliance, of course, measures other aspects of the lung than how quickly and easy you can empty it. So I hope this sort of illustrates the differences between the devices or the techniques, but it also illustrates that you learn different things about the lung using the two techniques. But now we're going to talk mostly about oscillometry. So oscillometry means that you have an oscillating flow illustrated by this sinus wave here on this graph. This is then going down into the airway tree, into the respiratory system. And when that happens, it's going to generate a pressure and a volume change. That is then recorded by the instrument. So there are a couple of sensors in the instrument, one keeping track on the flow, one keeping track on the pressure, and one not illustrated here. We also calculate from the flow, we can calculate the volume. The interesting thing is that depending on the condition of the lung, the pressure and the volume changes will differ slightly. So if you have a lung that is very flexible and very compliant, you're going to have one type of delay in shape of the pressure curve here and the volume. If on the other hand you have a lung that is stiff, or a lung where parts of the lung maybe have been de-recruited and not participating anymore in the ventilation, then the pressure curve is going to be having a very different appearance. So it's kind of intuitive to understand and realize that this should give rise to differences in lung mechanics. And so this is the data we use in order to calculate resistance and reactance. Pathology has a nasty habit of appearing in places where we can't readily see and get to it. And for lungs, this happens to be down in the smaller airways. So we're talking about airways, starting generation 6 or so, and then going down to where the respiratory bronchioles start. So this is the area where most pathology, when talking about asthma, COPD, are happening. But also interstitial diseases typically manifest themselves here. So the problem with spirometry is that spirometry is primarily measuring what's happening in the larger airways. That is what is the limiting factor for spirometry. Oscillometry, on the other hand, thanks to the fact that we're measuring around FRC, actually can measure what's going on out in this area here. And this is, of course, something that has been recognized for a long, long time. Actually, the image here and this statement here, the silent song, comes from 1960s. And this was just a statement in a paper from 2014, essentially saying the same thing. You need to look at the small airways if you want to know anything about the disease. One further aspect to this is that if you use low frequency oscillations illustrated by the blue line here, that tends to cover the whole system. Whereas if you use higher frequencies around 20 hertz, then you're going to get a good measure of what is going on in the more conductive airways. This is an oversimplification, but it's good enough for now. So this is one of the reasons that we can use different frequencies and capture different parts of the lung, the whole or the central. And of course, you can subtract the two and get something about the small. This is the way oscillometry is always represented in some shape or form. Different devices do it differently. This is the way we have chosen to do it, which adheres to pretty much the mathematical and physics standards. You plot impedance, which is always a Z or a Z, depending on what part of the world you're coming from, plotted against frequency. And here we have the resistance as the top here, and reactance is the bottom here. And a few things can be noted here. First of all, the blue here would be the low frequency. Here we have the higher frequency corresponding to the colors here in the graph or in the picture, and the corresponding here for the reactance. Resistance is always a positive number. Reactance goes from negative to positive. And we're going to talk about why that is in a moment. So this is what you need to remember. Also remember that always report both resistance and reactance values. This is a technique that builds on the impedance calculations, and impedance is always reported with a resistance and a reactance number. You can't do the one without the other. They come in pairs. They're like Siamese twins. So before going into all the details, we're talking about how to measure. So this is, sorry, this is not our device. This is actually, again, an old one. I think it's just hilarious. I need to show this to people. This guy is actually a Swedish guy who happened to be in Harvard at the time, and they did this incredible experiment where he was sitting in some sort of body box, and then this thing here is the oscillator. This is the wave generator. You can see the tube here with all the transducers and whatnot, and well, the mouthpiece. So essentially what we have today, if you look at tremor flow, is this big box here, including the mouthpiece, is just now shrunk down to something that you can hold in your hand. Either way, so this is the way it looks today. A bit niftier, I think. So here we have our esteemed colleague Lucas, and he's equipped here with a nose clip. He's supporting his cheeks, and this is the way you should do oscillometry all times. If you don't support your cheeks, you're going to start measuring compliance of cheeks, and typically we are not very interested in compliance of cheeks, so this needs to be there. And you don't want to leak through the nose, because that would obliterate the measurement. So you put the device in the mouth of the patient. You make sure that they're breathing. Not always will they do that, in particular if they're used to doing other maneuvers. They are waiting to receive the order to blow forcefully or something like that. So look for the patient's quiet breathing. Press the button on the device, the oscillator would start, and the oscillations are delivered on top of the patient's own breathing. So now we have this blended signal. And I just said that we apply the signal, not the patient, right? So we need to get rid of what the patient was doing. And of course, that's taken care of by the software that will filter out the patient's breathing pattern and will keep the oscillations that the device applied. And this is what we're going to use to calculate resistance and reactance. So here's a little video clip for those of you who haven't seen the device in action. I'm not sure the sound will go through, but it's pretty intuitive what's happening here.
Next time you your hands over your cheek like this, press against it. Okay, I'm going to
So that was the whole thing for one measurement. In order to do a complete test, you should repeat this at least 3 times. And this is by guidelines issued by ERS and ATS. But that's a quick thing, as you saw. Each test takes 20 seconds. So you're done in a little over a minute. Everything goes smoothly. So this is what was on the screen that you saw there next to the girl. Down at the bottom here, we see the tidal breathing of the subject. Next one is the flow, and up here we have the pressure. So you see all the 3 variables that we measure: volume, flow, and pressure. If you don't remember anything else from this talk, remember flow, volume, and pressure, please, because you need to do that in order to do lung mechanics. The small excursions here, that is the signal that we apply. So you can see that is a lot smaller than the flow that is generated by the patient. So it's a small flow on top of the regular breathing. You feel it, but it's not uncomfortable at all. So now we're going to get into the interesting part here. How can we understand respiratory mechanics based on oscillometry? So going back to this pipe and balloon model here. And this is a quick repeat. Everything that pertains to resistance is included in this parameter. You can call the pipe component if you like. It is anywhere there's significant pressure, a significant flow, that will be lumped into the resistance parameter. And typically resistance is increased in lung diseases, such as asthma, COPD. You see that they're increasing in resistance because the airways are getting smaller, contracting. Reactance, on the other hand, sort of related to the balloon component and also the gas volume, the air volume or mass in the whole system. But anything that is relating to the air volume, air mass, will be lumped into the reactance parameter. So these are the two major outcomes. It's not more complicated than that. Typically, reactance is decreased in lung disease. Remember the graph, we had one positive, that was resistance. The other one, reactance, slightly negative. And if the person is getting sick, typically it's getting more negative. So they're just getting further apart, these two parts. So now we're going to look at that. First, look at the resistance. So resistance is interesting because we kind of all intuitively think we understand what resistance is, but it's just resistance in any kind of conduit, electrical or flowing water through a pipe or a garden hose, or air through, a hose or our airway system. Interesting thing is that in a healthy adult person, over the frequency range we are using, which goes from 5 up to roughly 40 hertz, resistance is a relatively straight line. I'm saying relatively because there's some individual variations here, but typically it's linear, at least from 5 hertz up to around 20 hertz. So that's usually healthy. Of course, the position vertically here also has an implication, but if it's linear, at least the airway system is working as an homogeneous unit. Compliance and reactance, as I said before, consist of two components: inertance and compliance. Inertance is something we don't really talk about. It doesn't really have a lot of, it doesn't have a physiological correlate, but it's important because it drives the shape of the reactance curve. If you have a open, healthy lung with a lot of air in it, the reactance will actually be dominated by inertance. And this line will just drop slightly under the x-axis here. However, if you have somebody who has more of a diseased lung, stiffer lung, whatever, this line will be dominated more by compliance. So this line will sort of wander up and down, but also the crossing here, called the resonant frequency, will move out to the right here when somebody has a sick lung, essentially. So compliance drives this line down, resistance drives this line up. And if it's heterogeneous, you're going to see a curvature here. So the outcome parameters from this, looking at the low frequency, if you remember those images with the lung and the sine wave going into them, I say low frequencies tend to capture the whole respiratory system, which is exactly what we see here. And the mid resistance here will capture what is going on in the more central parts of airways. If you see a curvature like this, you can then calculate the difference between the two. And this has been shown in a number of publications and research reports, that this can be correlated to heterogeneities in the small airways. So this means that if you saw the line just shifting up, that would indicate that the lung was homogeneously getting, narrower and narrower, or the airways narrower and narrower, or that there was a big central airways resistance increase. That will shift the line upwards. But the curvature comes from the heterogeneities in the small airways. Because remember, almost all lung diseases are patchy in nature. You don't have homogeneous asthma with the same identical inflammation everywhere in the lung. It tends to be very patchy. COPD is typically not distributed homogeneously throughout the whole lung. It's also a patchy thing. So this shows up at this as this frequency dependence. So this becomes a very important parameter for that reason. Now we're going to look at the reactance. I said that this line tends to drop down and move out to the right when the lung gets obstructed. So why is it doing that? Well, if you think about a lung being oscillated, that is big and open, well, air can go pretty much anywhere, little obstruction for the air to move around. But if, say, the lung was really sick and the patient is now down to like 50% of their lung volume, which is not uncommon in COPD, you will see that the flow volume that we are applying when we do our oscillation now has to be accommodated by a smaller lung. And a smaller lung applying the same amplitude oscillations will lead to higher pressures. Okay, so how can we correlate this? Well, look at the units for this AX, as it's called, area over the reactance curve. The units for this is actually the units of elastance. It's pressure divided by volume. So when that increases, you've got a stiffer lung. Sorry for the confusion here. Elastance and compliance are just reciprocal of one another. So you depending on what order you divide, you're going to get either compliance, which is volume divided by pressure, or pressure divided by volume. That's elastance. So this is a clear indication that you have an obstructed lung. Again, this applies to mice and men, so nothing new under the sun here. At the end of the day, these two parameters tend to be the ones that are the most sensitive and that people report most of the time. Looking at the resistance at 5 Hertz is also a good indicator because it gives you information about the whole resistance of the whole respiratory system. And that is, of course, interesting to know. So this pretty much boils down to these key patterns that are relatively simple and I hope relatively easy to remember. If you have a normal lung where everything is open and no thickness of any membranes or anything, you should expect resistance to be a relatively straight line. The reactance curve should be up close here towards the x-axis. AX should be a small number, typically in the lower single digits, below 10 at least. R520, of course, close to 0 because this is a straight line. If you happen to have a central obstruction, as I said before, or rare cases, some sort of homogeneous process, which you might see sometimes in people with a parallel shift upwards of the resistance curve. But in those cases, you see that reactance is spared because those people don't have a peripheral inflammation going. They just have a central airways thing going, whatever that is. Peripheral obstruction. Now it's getting interesting. And what you're going to see here is typically a shift upwards of the resistance because, you know, this is narrow here. You're going to see a curvature here because you got heterogeneity in the small airways. And down here, you're going to see this shift down to negative numbers of the reactance because of the obstruction, because some of these areas will actually be totally shut off. And some areas going to have really thick and stiff lungs going on or tissue, which is further going to push this line down. So this can go as bad as it possibly can, and is something you see clearly in COPD and asthma. So this is just the screenshot from our software with the tremor flow. And I'm not going to go over all the details here, but I'm going to highlight a few things here because there's sort of good things to hang up on your memory, hang a memory on. So to the left here, you can see all the individual measurements that went into the standard test. Standard test, as I said before, at least 3 good measurements. So this is good. Here we see somebody with a reactance that is just around normal. We see a resistance around normal. And how can I know that? Well, see, there's a line here with the number 1. This is the identity line or the normal line for a person, this sex, age, weight, and height. So this is what is the expected for this person, and right around where he or she should be. If you know where normal is, well, then you can calculate statistics. And there's something called Z-score or Z-scores. And if you have a Z-score that is more than 1.64 standard deviations from the normal, then you're abnormal. So that's just the way statistics work. If you're perfectly healthy, you should expect to be right around 0 in Z-scores. So this is a very efficient way of keeping track on if somebody is healthy or not. Other numbers of interest here are something called the CV, which is up here in the right-hand corner. This is the coefficient of variance. And the coefficient of variance is the variability between these 3 or more measurements. And that number should be as low as possible. Under 10 is preferable. 15 might do, in particular in kids. But those are the recommendations. R5 minus 20 should be right around 0, and you can see it is. AX is, as I said, low single digits. Try to remember these numbers in your head: 2.4, 0, and 1.2. And we're going to look at what's happening if you have something going on. So here's somebody with a central obstruction. We can tell that because this is essentially a parallel shift of the resistance curve up above the upper limit of normal here. And we can see that this little marker here, this diamond, is now above the upper limit of normal. So we more than 1.64 standard deviations away from where he or she should have been. We can see, oops, now we doubled, right? And the CV is also higher. So there's some variability here. R520 is still close to 0. And we can see the Z-score is right around there. And same for AX. So this person has normal periphery, but some sort of, central obstruction going on. Here's a case which I think is very interesting, actually. We should start out from the left. We can see that 1, 2, 3. Oh, they did 5 measurements. So why did they do 5 measurements? Didn't I say 3? Well, I said at least 3. If you do 3 measurements and you see that something is not looking right, either you observe that the patient was fidgeting around or maybe letting go of cheek report, something like that. Red flag. Repeat the measurement. If you see that the CV out here is above 15, you definitely need to repeat your measurements. And we can see here that the noise is always biggest at the lowest frequencies. And this is always the case, both in resistance and reactance. So we don't know what happened here, but for some reason they decided, for good reasons, to do more measurements. In either case, the mean value here, because we calculate the mean, there's nothing best to be obtained with oscillometry because the patient isn't really not involved in the procedure, right? They're just the subject to be measured on. So this is an average of all the measurements. You can see the average doesn't really reach the upper limit of normal. So if we were to look at just the R5, the resistance of the whole respiratory system, this person doesn't really go above the upper limit of normal. So if we just imagine that we only did an oscillation at 5 Hertz, we would say, and just looked at resistance, would say, yeah, this is, getting close, but it's not like totally abnormal. But we look at the frequency dependence of this poor person. We're going to see, oh, now we have a 3.21, and we've got the Z-score 7.4. So this person is more than 7 standard deviations away from his or her expected normal. So this is highly abnormal. This indicates small airways heterogeneity. looking at the reactance. Reactance is abnormal no matter how you look at it. The whole line is definitely under the lower limit of normal. It's crossing way out here, somewhere around 35 Hertz. And we can see that the value of the area over the reactance curve, this triangle here, is 62 with a z-score of 3.2. So again, this person is abnormal, has significant airways obstruction in the small airways. So heterogeneous resistance, small airways, and with a degree of obstruction. Here's another patient. Again, they repeated the measurements a few times to be satisfied. We can see this person actually had a resistance that's slightly above the upper limit of normal. And that's indicated here with this square out here. I say the CV here sucks. They should have either removed a bad measurement or they should have done even more. Either way, this is the way it came out. Looking at R520, again, we have a z-score of 6.4, highly abnormal. AX, again, higher than it should be with a z-score of 4.6. So again, we see that overall resistance is actually abnormally high. There's a frequency dependence, heterogeneity, small airways. We see the obstruction in the periphery of the lung. And this obstruction is so bad that this line doesn't even cross the x-axis. So I would say this is probably pretty severe. Another little thing that is really cool to use this instrument for is to do a bronchodilator test or a pre-post test. And it's very easy to do. It's just you do one test, just as we just described, and this is the dark blue line here, resistance, reactance. We can see both of them look abnormal. They're out in the red here, so totally abnormal. When you've done that, you can actually just click this button here that says RX dose, and that would trigger a little menu that you then prompts you to give the patient whatever bronchodilator, in this case, use albuterol, and then you wait whatever prescribed time, and then you do a second measurement, which is this post measurement. And the results are then plotted here in this graph. And we can see that resistance is now down to normal and reactance is, well, almost normal at least. But the important thing is that the reversibility is significant if it drops 35% or more, or in AX, 65% or more. So these are both highly significant indicators that this person is very reversible. And either this is a new diagnosis of asthma or the guy didn't take his medicine. I don't know. If you have any hesitancies about the quality of a measurement you've done, you can go into something called View Time Course, which is a little button up here. And we can see that the device actually is capturing a lot of things that the patient might be doing. Remember, we want to deliver the signal. So if the patient starts trying to vocalize and singing or whatever they try to do in the device, that's going to add weird frequencies. And if they don't belong to the measurement, the device will typically take them away. And that's what the gray out areas here indicate. Then the patient, continued breathing normally and everything was fine. So those are included. Then there was a swallowing or a glottic closure or whatever, resulting in these abnormal spikes. And that is also typically captured by the device. Finally, if the patient lets go of the mouthpiece, that is also typically captured by the device. I would say if I were doing this and I discovered this, even if there's a lot of episodes here that were good, I would actually rather be safe than sorry. I would just do a fourth measurement here and hopefully not capture this stuff, just to be good. if you're doing this and you, for some reason, find that there is something wrong with the measurement, could be that profound leak or repeated swallowing or just fidgeting around. Kids often do that. And you have a CV that is above the limit, you will get a warning sign here. And so if you don't have 3 measurements, you will have a warning sign. If you have 3 measurements, but one of them is below the set quality, you will get a warning sign here. So, so you want to repeat until you get rid of that. Usually no big deal, but it's important to do. Finally, when you're done your measurement, your test, you can get a report. It's a PDF report. You can print it or you can store it for whatever you like. And you can also, in particular those of you who are interested in research, you can actually export a lot of details. You can export all the data you see on this screen here and much more. And it's also integrated with a few collaborators we work with, such as Morgan and ERT Clario and a few more. All right, time for the real life data. I wish we would have been in the same room now, because we could have had show of hands and whatnot for what people think is good or bad. But nonetheless, I'm going to go through these. So I should say these are really real life data. People have shared them with me, and often they just send me a photo of a recording or a screenshot, or in this case, it was a PDF of a copy. So they are not the world's most perfect, but yeah, that's the way it is. So this is this is actually a doctor in Sweden who has a patient, and every March she shows up. She's like scheduled like a train. She will show up on the same day after the birch has come out and starts spreading its pollen. She will show up. And she got horrible allergies. So this is the first day she came in, did oscillometry. He was pretty new using the device, so he should have done a few more measurements. I give him that. But either way, it doesn't matter. It wouldn't change the diagnosis and the outcome for the patient. She's bad enough. You can tell that she's way above the upper limit of normal in resistance, way below the lower limit in reactance, 11.4 for resistance, high frequency dependence with a Z score 12.4, which is incredibly high, and 130 for AX. So she's really sick, and this is what she was prescribed. And it's a long list of things, from Montelukast to Pulmicort to Spiriva, Innovair, Xolair. I mean, almost everything you could find in a pharmacy she was given. She came back just a few days later, or a week later, to see how she was doing. And no, she actually did worse. So some of this variability here is actually not due to badly done measurements. These are probably more reflecting on the variability of her asthma. So this is how bad she is, that her airways will actually vary from essentially minute to minute. So I would say that some of this variability could actually be indicator of a disease, as well as maybe the quality could be better too. And I think this is very interesting. Again, it doesn't take away from the fact that her resistance is way above 20 here, and reactance is, AX is 123. So she's definitely not being much helped by this cocktail she got. Now she was prescribed prednisolone per oral for 3 days. And 3 days later, she showed up. Okay, so let's try to remember this. 21 to 123. Here we have now 8 to and 49. So obviously, she's now heading in the right direction. And I actually talked to him on the phone and said, well, I'm a bit mystified. I said, because she says she feels a lot better, but she difference resistance and 100 units of AX. So she's heading in the right direction. The mission here with some research reports. I said before that we can relate AX, the area of the reactance curve, to the volume of gas in the lung, right? And if it's obstructed, we see a smaller lung that oscillating with the same amplitude, and that it's rise to a large AX. And here are a couple of examples from asthma and COPD. So, and relatively mild asthmatic here, you can still see there are areas homogeneously gas will appear more get imaging from asthma, and the curvature and frequency depends on resistance. Somebody with more severe asthma, you can see that the frequency dependence increased, and the area over the reactance curve is also increased. COPD, very analogous to the asthma situation. Maybe, and this is sort of my impression, that COPDers have much more of a reactance signal than resistance signal. They always have some resistance increase, but it tends to be more expressed in the AX, the reactance part. So these people are more obstructed, which shows here. Asthmatics have a bit of both. The bigger difference is really if we gave the asthmatics bronchodilator, they would tend to normalize, whereas the COPDs would not, at least not to the same degree. Down below here, they have a couple of never smokers, who of course have totally normal oscillometry, and a couple of ex-smokers who had they were smart enough to quit in time. So they also look pretty normal. Here we have another female asthmatic ex-smoker. She came in one day for whatever reason, and she was there for a few hours. So they started the day by doing oscillometry. And so this is somebody, she's obviously under treatment, but probably not optimal treatment. We can see that she's got somewhat elevated resistance here, and reactance is a bit low, not as bad as the previous one we saw. And then just a couple hours later, they did another test, because now they're going to do a bronchodilator test on her. So this is the initial baseline before the bronchodilator. So looking at this, well, reactance is sort of similar. She's actually a little better, but resistance now looks like, homogeneous or central airways obstruction. So this is how variable she is over just a couple of hours, which I think is pretty fascinating. And you would never capture these small changes using spirometry. Then they gave a bronchodilator, and she went from wherever, well, she reduced like 26%. So by the ERS standard, she was not fully reversible. Maybe that's not a big surprise, because as I said, she's a patient that has treatment. So, but it just illustrates there's room for improvement, even if you are under treatment. Because remember, you're actually over the limit of normal. With the bronchodilator now within the range of normal. So despite this not being 35%, I would still claim that from a clinical point of view, you might still be able to say that, well, there's room for improvement. Maybe we should change your medication, or maybe you should get rid of that parrot or cat or whatever is bothering you. The AX, on the other hand, was actually very significant. Remember, the cutoff here is 65%. So, and this is also interesting because she was already relatively okay, but again, there's room for improvement. So, not fully treated. So this is an interesting case. It was sent to me just a little while ago, and I'm not going to tell the doctor's name. But this was the question: why is this patient reversible on spirometry but not on oscillometry? Well, that sounds like a good question, doesn't it? Well, actually, if you were to start zooming in on this and try to understand what's going on here, the first question should be, are the measurements of acceptable quality? All right, let's go to the oscillometry first, just because that's what we know something about, right? And we can say that, well, they're very tight. And nothing, there's very, very little variability. The CV is not displayed on this graph, but it was definitely within the limit of normal. We can see that this patient very pronounced frequency dependence, so heterogeneous airways resistance, small airways. Got a big AX, and that is also indication of peripheral obstruction. The bronchodilator test didn't shift this at all. So this is a fixed obstruction, not sensitive to bronchodilator. My guess it would be COPD or something like that, but I don't know enough about this patient to say that. Now looking at spirometry here, well, just summarizing the oscilometry here. Looking at the spirometry, it's actually not acceptable. First, if you look at it, well, the table here is very small, so I'm sorry if you can't read it, but TLC was not reached. And how can we say that? Well, because the forced inhalation was negative and the forced IVC is larger than FVC. And we can see that this, because this line actually goes out to the negative here. So when you inhale after blowing out, if you go negative here, well, then your first breath in was not full enough. Number two, not reaching total lung capacity can reach in a false too low FEV1. And then when you do your proper, and this is the second after the bronchodilator inhalation, and you now do it properly, that might give you the impression that you're reversible because now you're starting at a higher lung volume. So, well, that was an interesting one to look at. Well, oh, here's a zoom in. Yeah, so here you can see the differences here. Here's another one, why is the oscillator looking weird? Yeah, it does. Again, are the measurements of acceptable quality? So as far as I can tell, the spirometry is actually okay this time. At least there's no difference between the two different situations with and without bronchodilator. But you look at the oscillometry, it's not acceptable in this case. So in this case, for whatever reason, they looked at R5, and because R5 gives you the CV, they thought, oh, this is okay, you know, good quality. No, you actually have to be a bit smarter than that. If you look at this, and you see that the original measurement down here, that one has very small errors. There's no variability at all there. All the variability is in the post-bronchodilator. So what is going on here? Well, my guess is that likely the patient did something. Could have been that they put the mouth in the mouthpiece, tongue in the mouthpiece, chin was pointing down, they were slopping their head down, or whatever was going on. Maybe they kept their vocal cords closed. I don't know. But if you're a well-trained respiratory technician or nurse, you should pick up that, wait a minute, with this kind of variability, I need to go back and look at the details and probably repeat the measurement one or a couple of times. And then you can go in and we can remove the one that is the outlier from the calculation, and you very likely would get a decent result. And the reason it's all in resistance is because if you look at reactance is not so sensitive to these, obstruction of the mouthpiece or whatever could be going on, because it's all volume. You can see there was actually a slight improvement with the bronchodilator. So this patient is likely reversible, but it's obscured by this weird resistance here. Let's see, I got a couple of things left here, if you bear with me. This, I think, is a pretty cool one. It was actually published in the paper we came out a year or so ago. And this is from my friend and colleague here at McGill University, Dr. Ron Duran. And he has this man, he's coming in, he's a regular customer, he's under his treatment and he's been for many years. And number one here is the way he normally looks. He looks like a healthy person. That's because he's taking his medication. Now, in 2015 to 2016, when he came back the next time, for some reason he decided to start cheating on his medication. And this is the way he looked when he came in for his regular checkup. Not surprising, he was complaining as well. So you can see frequency dependence, signs of obstruction, all the classical signs. Yeah, so doctor told him, you better start taking your medicines again. And he was on budesonide formoterol combination. And he did so, and he came back, I think about, a couple of months later, and he was certainly better, but not good enough. So then he was put on ultrafine particulate steroid, cyclicinide, and now, just a month later, he's back to where he should be. So I think this is a great example how you can use oscillometry to monitor patient and make sure that they're taking their drugs as they should. Here's another example from the same publication. This is somebody who has, entry-stage COPD. And we can see that they have this slight frequency dependence, a little increase in AX, and it's commensurate with all the changes in spirometry. You have to remember, spirometry is how you define the stages of COPD. We suggest in this paper that you might be able to use stages of AX as a tool to stage COPD. Of course, this is something that we discuss. It's nothing that's approved. But in any case, what we can see is that there are patients who are borderline here. And so it brings out a question, maybe we could detect people that are even earlier in their career as COPDers, or maybe it's time to actually quit that smoking or doing some other changes in your life. Children, of course, this is a great example where oscillometry could make a big difference. This is a recent paper from Denver, the Children's Hospital there. They studied children with Down syndrome, and people with Downs, they can have all kinds of different impairments, which makes it difficult to follow them, or their lung function at least. So using something like oscillometry is fantastic because they can usually cooperate unless they have really big problems keeping a tight seal around the mouth with the mouthpiece. Everything else they can do. So this little girl here is obviously doing just fine. And so this is a feasibility study. What they show is that they getting meaningful data, it's highly repeatable, and it gives, reliable and reproducible results in this group of patients, which is fantastic. So now finally they can actually follow these patients, they can treat them and make sure that they're doing well. Another one from Denver. This is a reversibility test in a boy 5 years old. You can see the before and the after in the blue and turquoise. Again, the changes were not statistically significant. And of course, this is somebody who is not doing terribly bad in any case. Again, this is up to the doctor because it's a clinical diagnosis if this is asthma or not. Either way, they're trying to use this technique in order to make sure that the kids are fine so they can leave the ER. Because if they're sitting in the emergency room for hours and hours, not only is it boring for the kid, it costs a lot of money and the parents are losing income. So getting them either on the floor for proper treatment or being sent home and everything is okay, it's important. Here's an example of a girl that is a little over 9 years old, obviously not reversible. She appears to be pretty healthy, at least in terms of resistance. Her reactants appear to be a bit low here, but this is something for concern. I don't know what the diagnosis of her was. All right, I'm at the end of my talk here. Just a little plug here for the TremoFlow, and one can have it with their arm here, and which has been a blessing for a lot of people now during the pandemic, because you can have this sitting in the clinic at one table, and you don't need to be really close to the patient, because you can maneuver the device from the computer with a long cable, and observe the patient from a distance. So I think with that, I'll be happy to entertain any questions, and feel free to ask me and Natalia anything you wonder about oscillometry and the thermoflow and whatnot.
Hola, Natalia, Leonard. Natalia, I don't know if you can see in the remote of the Zoom, it's questions and answers. Some doctors have been questions.
There's lots of, all right.
There are, I don't know if you can, it's not on the chat.
Yeah, it's in the Q&A. Yeah, I see
yes.
that.
I don't know if you can translate those questions to Leonard, and you can help us.
Yeah.
Please.
Okay, so they're asking about them. So in Mexico, they have a reference value of equation, but it was generated with iOS, so impulse. So they are asking if they could use these values, the reference values, to interpret the studies in Mexican children, or which will be the reference values that will adjust to their population in Mexico.
All right, yeah, that's a good question. I think one simple answer would say that I don't know if there's like a big difference between the Latino population and what is being sort of north of the border. We are currently waiting to get a publication out in children, which will be a multi-ethnical group of patients. It's been collected here in Montreal, but I know that there are Latino kids in that cohort. How well that will work with the Mexican children, I honestly don't know. Yeah, that's the best I can tell you. From what we see in adults, it doesn't seem to be like a big difference between different ethnical groups. The biggest driver in terms of lung impedance is really the height. So if somebody is really small compared to their age, or expected height for their age, then the values might be off. And we can see that in India, for example. In India, even with spirometry, doctors treating patients who are living in more well-to-do societies, bigger cities, they like to use the European reference data, which is pretty interesting, because if they try to use the Indian data, they're going to go to wrong answers. And one doctor told me, I wouldn't be able to diagnose anybody with COPD because all their spirometry is too good. So in terms of kids, it remains to be seen how well these reference data will actually reflect your population.
Ok, muy bien. Tenemos varias preguntas y felicitaciones al doctor Leonard por su excelente ponencia. El tema realmente está bastante interesante y ahorita tenemos alrededor de 154 personas aquí asistentes escuchando al doctor porque nos interesa bastante este tema. Y aparte de las otras 5 preguntas que están en el chat, hay otras preguntas de los asistentes. Y una de estas es, ¿cuál es el parámetro oscilométrico más sensible para evaluar la respuesta a broncodilatador?
Okay, so they are saying which one is the most important parameter in oscilometry for the bronchodilator test? Will be
actually, both resistance and reactance are independently important, because you can have somebody who is reversible in resistance, but not reactance, and the vice versa. You could have somebody who has reactance reversibility, but less in resistance. I think that just reflects that the disease can manifest itself differently in different patients. Some have more of, airways, dimensions changing. Others have more of opening or closing of peripheral units and will show up more in reactants. So if reversible about 35% or reactants 65%, either is a qualification for a reversibility test.
Ok, y esto responde a la pregunta del doctor Carlos Valderrábano, que dice, en la prueba post-broncodilatador, ¿cuánto es considerado una respuesta positiva? ¿Verdad? Es lo que acaba de mencionar el doctor. Y otra pregunta es si podemos evaluar la respuesta broncodilatador en la frecuencia de resonancia y también en el área de reactancia.
So yeah, they are asking if they could, like, the response of the bronchodilator test can be also measured or evaluated in the resonance frequency and AX.
AX, yes. As I said before, if AX is reversible, yes, that's significant. That's a significant bronchodilator test. Resonant frequency has not been defined as such. Of course, typically resonant frequency will change, but a change in resonant frequency alone would not necessarily be by guidelines has not been defined as a successful bronchodilator test.
En la oscilometría, dice, ¿es un estudio que se complementa o que se excluye a la espirometría?
They're asking if oscillometry is a complement of the spirometry, or they are like excluding spirometry.
No, it's additive. It's complementary today, and I think it will be for the foreseeable future. That being said, I know of a number of physicians who use oscillometry as their primary tool to monitor patients. Remember, I saw towards the end, I showed this man who comes in and he had been 4 times to the doctor, right? And while they were doing spirometry there, oscillometry would have been totally enough to do on him, because in that case, it didn't contribute. In fact, if you have somebody with just a mild disease, you may not see anything with spirometry. Or if somebody is just cheating a little on the medication, spirometry might look okay, but the patient might still have wheezing or coughing up things and stuff like that. And so your conclusion would be that you're probably not perfectly treated, and oscillometry would give you the evidence for that. So I think when it comes to monitoring, I would think that oscillometry, my speculation, I speculate that would sort of replace spirometry, because you could do this so much more frequently and much easier.
Ok. Otra de las preguntas es si usted recomendaría realizar una oscilometría para seguimiento de la vía aérea pequeña para seguimiento o para detección de afección de vía aérea pequeña en pacientes con rinitis alérgica.
Yes. Okay, so they're asking if you will recommend oscillometry for the monitoring of the small airways for patients that have a rhinitis, allergic rhinitis.
Well, a lot of patients who have allergic rhinitis also have, allergic airways. So yes, I don't see why that would be a problem. The crux is, of course, that some patients, you can successfully treat what's going on in the lungs or in the nose, but not the other way around, right? So in that case, this would sort of give you important information if the two are linked. So I think, yes, I don't see any problems with that.
You're muted.
Sorry. Another question is, posterior a iniciar el tratamiento en un niño con asma, al empezar el tratamiento con un corticoide inhalado, ¿existe algún tiempo en específico para repetir la oscilometría? Y ¿Cuándo deberíamos notar un cambio significativo en las resistencias?
Okay, so he's asking if after starting the treatment to a child with corticoids, now corticoids, there isn't a specific time that they should wait to repeat the study, or like how will be a significant clinical change in resistance? Like what will be considered a significant change?
Okay, so what I would do there would be to bring out the first measurement that you did when you diagnosed or the first time kid came in. Look at, I mean, the two things you can do. One is to look at the SED scores and see where the child is in terms of SED scores. Take note of those, and then they're treated and they come back, I don't know, whenever they come back, right, after being on treatment for a while, and then you compare and look at the SED score and see if they improved. If the oscillometry, you know, the little colorful gauge scale to the right, if it moves from the red into the green, well, then you're where you should be, right? If not, well, then maybe there's something else they should be treated with, or increase the dose or something. There is another thing you could do, and that is because there are, for some kids, there might be an issue depending on their age and size, where the current reference data may not be fully developed. And one thing you could do, and this is actually being promoted a lot in adults too, is to do bronchodilator test. And remember, I had this picture of a kid, I think it was from Denver, who had a bit of reversibility. It wasn't the 35, I think it was 20, 25 or something like that, right? And that to me suggests that, well, there's room for improvement here. Whether that room of improvement is clinical relevant or important, that's going to be up to the doctor to make that call, to decide whether it's worth more medication or a change in medication to go this extra step. We also have to remember that even if asthma well treated can actually be variable from day to day. So you could have a bad day, you can have a good day. It's definitely something you could do, yes. So I think doing this for somebody who's on corticoids or anti-inflammatory makes a lot of sense. So these are two things. Look at the SED scores, do pre-post bronchodilator to see if they can improve. Because doing that is such a quick and easy test, and it's not, you know, unpleasant to the patient. So it's actually a very efficient way of doing it.
Otra de las dudas es si considera que hay una relación entre la oscilometría con afección de vía aérea pequeña y los resultados de feno en los pacientes con alergia respiratoria.
So they are asking you if you consider there is a... ¿Me repite la pregunta otra vez al principio, por favor?
Sí, sí, hay una correlación entre los resultados de oscilometría y feno, de fino.
Okay. If there's a correlation between pheno and oscillometry, yes. That's a good question. The problem with pheno is that it's only relevant in patients who have eosinophilic driven asthma. And that is true for a lot of asthmatics, particularly allergical asthmatics, but for the rest, it gives you no information whatsoever. So if your patient has eosinophilic asthma and subsequently high pheno, they tend to go together. So yes, there is some correlation there. But if you have somebody who, and this is true, some people can have a change in pheno before you see any changes in lung mechanics. Because you can dampen the inflammation or the inflammatory signal from the eosinophils and the subsequent release of NO. But that might not be the whole story. There might still be other things happening that is not taken care of by that treatment. So I think they are additive and in particular in patients who you don't know that much about, it's of course a good idea to do both pheno, spirometry, and oscillometry to get the full picture, and maybe even put them in the body box. You're muted.
Another question, otra pregunta es, ¿cuál es la edad mínima en su experiencia que han realizado oscilometría en niños?
What is the minimal age in your experience that
Okay.
oscillator has been done in children?
Okay, it's been done in kids from 2 years. That's not to say that all 2-year-old can handle it. It's not that they can't breathe in the device, they can, but it's just the whole situation, you know, this small little, you know, almost baby, and then they're going to have this big, you know, to them very big device in front of their face, and the whole situation. So it was just the other day, somebody, you know, showed me some data, and they said, well, we could do this in 4 out of the 5 kids we had there, but the 5th, he was just never stopped crying. So it was not that the device couldn't work, but the kid was just scared for the whole situation. I talked with the people in Denver. They have a lot of experience now. They worked with the Tremoflow, I think, 3 years. And they have sort of found out just making the kid feel comfortable, calm, and making sure that they are not stressed by the situation. Maybe let them play around a bit with the mouthpiece, and you know, then you can hook it up to the device, and they I don't know how they do it, but they get a lot of 2-year-old actually to do it. Not everybody, and of course the maturity for a 2-year-old can vary a lot. We all know that who have had kids. So but I say from 3, almost all children manage to do it. Yeah, that's what they tell me. Yeah.
Ok. Otra de las preguntas es si la oscilometría es mucho más sensible que la espirometría para detección de obstrucción bronquial.
They're asking if oscillometry is way more sensitive than spirometry in, repite la última parte,
en obstrucción bronquial.
In bronchial obstruction.
Yes, it probably is. If you, again, because we're measuring right around FRC, and if people are experiencing different difficulties breathing at normal range, then it definitely would be picked up by oscillometry. So I think spirometry would have an advantage when it comes to things that depend on, you know, having to empty a full lung and do that forcefully, which is of course a measure of what's going on. But say if you have bronchopulmonary dysplasia and things like that, where you have a firm collapse of larger airways, that will show up in spirometry, and not necessarily if you're breathing carefully around FRC, but even so, often in BPD, people do see changes in oscillometry as well. In particular, because it's a more central airways phenomenon, the whole resistance moves up. So it confirms that part, and usually the reactance is spared because it's not a peripheral inflammatory disease necessarily. So it's still valuable that you can sort of sort out where the things are located more centrally or peripheral.
Ok, en relación a eso, ¿en qué orden se debería de realizar la prueba con broncodilatador? Si tenemos tanto espirometría y oscilometría, ¿en qué orden realizaremos la prueba post-broncodilatador al paciente?
Which one will be the order to perform a spirometry and bronchodilator test in a patient?
Okay, that's a very good question. So you always want to do oscillometry first, no matter what you're going to do otherwise. The reason for that is that the big forceful maneuvers where you go from TLC down to residual volume, in some patients could even trigger a reaction so that they have an exacerbation of their lung disease, which would then spill over into whatever you do afterwards. So doing oscillometry first is important. When it comes to doing bronchodilator test, if you want to do bronchodilator with both spirometry and oscillometry, the same sequence applies. You come in, you do oscillometry, you do spirometry, you go in the bronchodilator, and then typically wait 15 minutes, and that's plenty of time for any, things to revert back to normal. You do oscillometry again, and then spirometry. Done.
Ok, muy bien. ¿Cuánto tiempo nos lleva a realizar una oscilometría completa con prueba post-broncodilatador?
How much time does it take to do a full test of bronchodilator with oscillometry?
Well, if everything works well and there are no problems, instructions and patient behaving well, you do your baseline measurement in, I would say, a couple of minutes. And then you give the bronchodilator, and whatever time you standard waiting is probably 15 minutes, and then another couple of minutes for the test. So you're done very quickly.
Otra vez estás muteada.
Yes, another question. Dice que si o está usando algún filtro antiviral y si eso puede influir en la impedancia.
Do we use any filter, PFC filter, and if that affects impedance?
Yes, the filter is part of the whole assembly, and the filter is actually the mouthpiece. So it's sort of one piece. The filter that is used with a tremor flow is proprietary. It's developed for the tremor flow to have low resistance, low dead space, and to have sort of high quality. So you could, you don't have difference between filters. When we factory calibrate the device, it is calibrated with this filter. So the filter is, the properties of the filter is actually subtracted from the impedance of the patient automatically. So it's not part of what you're measuring. This also means that you should always use that filter and nothing else, because if you put something else in the device, you might do a measurement, but you don't know what you're measuring because the device is not calibrated with that filter.
Ok, muy bien. Otra pregunta de la doctora Carla Robles dice, en Ecuador, ellos están observando que en pacientes post-COVID-19 hay un aumento en la resistencia a 5 Hz. ¿Qué opina usted de la utilidad de la oscilometría en pacientes post-COVID? O si hay alguna relevancia clínica en este hallazgo.
Okay. So that's the question I have here in English, right? All right. Yeah, the post-COVID is an interesting one, and there are actually several studies ongoing right now in COVID. And I saw a publication just a couple of weeks ago from Finland. It was not post-COVID, but they followed patients out, and there's a very interesting study. It's actually open access. The first author is Tamminen, Tamminen, and it is definitely useful. And actually, there's an interesting sort of history here going back to 1976. That was actually the first time oscillometry was used in influenza. So they had a group of patients who were diagnosed with influenza, and they underwent oscillometry, and then they followed them out and saw that they cleared. So yes, oscillometry is definitely sensitive to those changes. I think it's a very interesting question about post-COVID, because if you think about it, people complain of shortness of breath. That doesn't necessarily mean that their airways are obstructed, or that the lung tissue is stiffer, or they have de-recruitment of the lung. It could be that the transfer of gas between the air and the blood is not working properly. So by doing an oscillometry test, and if that comes out normal, that will tell you that the airways are open, the lungs are sort of physically working okay. It doesn't tell you anything about the gas movement over the lungs. But then you combine that with whatever cardiopulmonary, cardiology and circulatory investigations you can do, and you can figure out where the problem lies. Because if it's not in the operation of moving air in and out of the lung, then the problem is somewhere else. So I would use that as an exclusionary tool. On the other hand, we have also seen patients like the Finnish study where they saw that most patients appear to have some impairment of moving air in and out during regular breathing. So then you might be able to treat that and help the breathlessness if that's the issue. So I think you can use it as a tool, but of course it's not the same disease as asthma and COPD, so we have to be a bit more clever about how we use it. Yeah, cool question. Thank you.
Thank you, Dr. Leonard. And more questions. Pacientes con asma que puedan tener una obstrucción fija hasta en el 24%. Existe pacientes que no mejoran en la espirometría. ¿Es más sensible la oscilometría para ver cambios en estos pacientes?
Okay, so they are talking about a case of patients that have severe asthma that is not responding up to 24%, and that spirometry cannot.
They can't do it.
Exactly, can do it. Is oscillometry way more sensitive than spirometry in this case, for example?
Well, I mean, it's interesting because, I mean, all techniques will sort of reach their limit of where you can use them, right? And if you have somebody with really, really bad lung function, and often also spirometry, they just don't do well trying to do spirometry. I would say almost anybody who can breathe at least something can also have oscillometry done on them. In fact, if I should really strict, you don't even have to breathe in order to measure the impedance of the airways, right? Because the device sends in the signal. Now the device expects a live warm body at the end of the device, right? So that somebody's actually breathing, but you don't have to breathe a lot in order to make a measurement. The device is looking for breaths just because that's a quality sign of the measurement. So it doesn't use the breath for anything. So as long as the patient is breathing, oscillometry should work, yes. What kind of answers you're going to get from somebody who is severely obstructed? Well, you're probably going to see an AX that is astronomically high, probably like close to 200 or something like that. Resistances, if it's COPD, is probably going to be very frequency dependent, but in particular AX will be very large because the lung is small, simply.
Yes, thank you. Otra de las preguntas es que si hay una variabilidad en los valores predichos para la población latinoamericana.
They're asking if there's any variability in the reference data for the Latin American population.
Right now, there's no Latino American reference data set specifically for Latin America. The data set that's being used, I think actually by all devices out there, or modern devices, I should say, rely on the same one, which was the one published by Ellie Oostveen and her collaborators back in 2013, which includes a somewhat wide selection of people, but it's probably dominated by Caucasians.
¿Habrá alguna ecuación de valores de referencia que se ajustaría a nuestra población? ¿Alguna ecuación?
Is there any equation that could adjust the values to our population reference?
No, there is not currently anything, and we don't know I don't think anybody knows what the potential difference is between Latin American population and any other population. That has not been, to my knowledge, done, and definitely not done with a tremor flow. That being said, we are working on getting and expanding the reference data for all kinds of populations, but this is just a job that takes a lot of time. It's actually relatively costly, and when I approach people to discuss if they're interested in working on collecting normative data, it turns out that, well, normal healthy people usually don't show up to lung doctor. So they don't see healthy people normally. So it becomes this sort of catch-22, trying to get somebody to work on getting healthy people in. So it's not an easy task to do.
¿Cada cuánto tiempo recomendaría realizar una oscilometría para seguimiento en pacientes con asma o EPOC?
How much time would you recommend to redo a oscillometry test for patients with asthma and COPD? Like how
often?
How often?
I would say that depends on the patient. You know, we were looking at this lady with a severe grass allergy. She came in after 3 days, right? and this gentleman who was cheating on his medication, he took like 3 months, you know, or something like that in between his visits. So no, I couldn't come with a recommendation for that. I think that has to be your call as a doctor, how frequently they need to be followed up. I mean, if you institute new treatment, you know, there's going to be some realistic expectation. You know, how long do I think it takes for this treatment to actually have an effect? And well, maybe that would be the indication for when the patient should come back.
Nos pregunta el doctor José Gregorio Martínez si existe alguna diferencia entre PulmoScan y el Thoracic Thermoflow.
There is any difference between the PulmoScan and the Thermoflow?
I'm not that familiar with the PulmoScan, but I know it's a device that doesn't have the same frequency range. I'm not sure really what their signals are. Yeah, I couldn't really say if there's what the differences are. We know that it's not been, you know, sold widely yet, so I don't think there's a lot of knowledge about it. There's certainly no big publications on it, so yeah.
Okay.
I haven't tried myself.
Okay, thank you. De Juan Robledo, le felicita por su charla, excelente plática, y pregunta cuál es el papel de la oscilometría en las enfermedades intersticiales como la fibrosis pulmonar.
He's saying thank you for your presentation.
Thank you.
Very good one. And he's asking what is the importance of oscillometry in interstitial in sickness, like for example, pulmonary fibrosis?
Yeah, that's a good question. And there's a lot of work going on in that area right now. There are a few publications on interstitial diseases. I wouldn't say there are any really big ones. I know there are some larger ones ongoing, but I'm not part of them, so I have no insight in how it's going and really what they're looking for there. The ones I've seen seem to paint a very similar picture, and that is that resistance is not affected much at all. So those patients, the ones I've seen, tend to have a pretty straight line resistance. It's a normal range. If you look at the reactance, it's very interesting. It seems like the resonant frequency goes out to the right, and there's a slight decrease in the reactance curve. So you get a relatively moderate increase in AX, which maybe wouldn't raise too many eyebrows if it wasn't for the fact that there's nothing happening in resistance. So that's how far I would go, and that is actually pretty interesting if that's the case. If you're thinking about, because it's not a part of this question, but I wouldn't be surprised if it came up, usefulness in cystic fibrosis. Now, cystic fibrosis is almost, I wouldn't say a history, but you know, with the recent new treatments that have come up with cystic fibrosis, you don't really see a lot of young, really sick kids anymore, at least the ones who have access to this treatment. It's pretty expensive, unfortunately. Another problem is that our lungs are very redundant in size. I mean, they have a lot of overcapacity that we usually don't use unless we are running marathons and stuff like that, which we don't. And so the lungs can go pretty far before anything starts showing up as problems. So in young kids, the CF kids I've seen where it's been tried, it hasn't really shown a lot of things. On the other hand, no other lung mechanics measurements show anything either. So we're sort of in good company there. What happens later on in life, that is probably going to be more depending on if they get infected and colonized with bacteria or not. And when that happens, then lung mechanics are going to go south in any case. So yeah, these two diseases are of interest. We haven't really seen too many publications yet, but you know, when people, the more this gets spread and used, the more publications are of course going to come out.
De la doctora Chris Saez, pregunta si existe una fórmula para calcular el límite superior de la normal en el eje AX.
If there is any equation to calculate the superior normal, limit of normal in AX.
There is no there's no formula per se. What we have in there is really the position of the curve per se, which relates to the reactance impedance part. AX is related more by the Z score, which is part of the normal values. So in terms of lower limit, I think yes, because of the Z scores, you will still have the same limit of normal, which is 1.64 standard deviations from your expected normal. So yes, it is there. The formula is the same for Z scores no matter where you go. Just look it up in any statistics book.
Nos hace un comentario aquí en el chat que existen valores de referencia para niños publicados por la doctora Gochikoa y el doctor Torres en más de 2,000 niños y adolescentes mexicanos y que fue con el IOS.
Okay.
Yeah, no, and yeah, they obviously have that. Yeah. If that has been published, we were happy to have a look at it, because some of those are actually possible to adapt for the thermal flow. Remember, the reference data we have in there right now is made up of several different devices together, and that's what the Eli Ostring group used at that time. So it would, you know, interesting to do. All right. Yeah, thank you. I got it here. Thank you.
Yeah.
Yeah, we could look into that and see if that is.
Ahí en el chat está la referencia de la publicación de los doctores.
Yeah,
y mandan excelente, grandes felicitaciones desde toda la República Mexicana y Latinoamérica. Nos están viendo desde Bolivia, Ecuador, Colombia. Excelente plática. Muchas gracias al doctor Lennart por compartirnos su experiencia en una forma tan amena y pues denota aquí el interés que tenemos a todo México y Latinoamérica de estar implementando estas técnicas de función pulmonar que cada vez se ha facilitado de tenerlas en el consultorio, en el día a día, para evaluar tanto niños y adultos con enfermedades respiratorias, asma, EPOC y otras enfermedades intersticiales. Sabemos que el sistema de toracis pues, nos da una gráfica con escala de color, verde, amarillo, rojo, que nos facilita la interpretación de los resultados. Es una escala, tiene una imagen muy amigable y fácil de interpretar, aparte de las curvas pre- y post-broncodilatador. No sé si nos un último mensaje el doctor Leonard para dar el cierre de esta sesión. ¿Nos quiere dar el último mensaje, doctor Leonard?
They're asking if you want to give the last message.
Okay.
To finish the presentation.
All right. Well, thank you so much for all your questions. You've been a wonderful audience. You know, I give this type of talks quite frequently, and not always do I get, you know, so many questions and so many interesting questions. So I really appreciate that. It actually means a lot to me. So thank you so much for taking the time with me. I hope to meet some of you in person if you're coming to ATS this year. I should be there. Just swing by the thoracic booth or maybe run into each other in a scientific session somewhere. That would be wonderful.
Muchas gracias. Les recordamos que en el chat está el link para contestar la evaluación. Es una pequeña evaluación muy sencilla para tener sus puntos del consejo. Les recomendamos que lo vayan abriendo. Se va a quedar aquí el link para que lo vayan contestando. Agradecemos a todos los asistentes, tanto del capítulo noroeste de SEMICA, especialistas, alergólogos, neumólogos a nivel nacional. Nos da mucho gusto tener esta audiencia y pues se ve lo que es el interés por estar actualizándose constantemente. Próximamente les vamos a estar enviando los webinars y los pósters promocionales de los siguientes webinars del capítulo noroeste, que cada vez se ponen mejor. Agradecemos al doctor Leonard, a Pulmonair y a Toracis por esta gran charla que tenemos esta noche. Gracias, doctor. Saludos. Gracias. Bye.
Feliz noche.
Goodbye. Good night.
Goodbye. Vamos a estar mandando les vamos a hacer llegar la grabación de esta ponencia, la traducción al español para que no se queden con ninguna duda. Y se va a quedar abierto el chat para que puedan contestar la evaluación a aquellas personas que requieran sus puntos de cónica.
Hasta luego.
Gracias.
Hey, great job, everyone. That was awesome. That was
Thank you very much.
amazing.
Yep.
Thank you. Have a good night.